And so I just wanted to welcome Rich and welcome everyone to this seminar. Just to give a little bit of an introduction to Rich. Rich is a Professor of Health and the Environment and leads the Places and Health Programme at the Social and Public Health Sciences Unit at the University of Glasgow. He's the co-director of the Centre for Research on Environment, Society and Health, also known as CRESH, which is an interdisciplinary centre focused on how physical and social environments can influence population health, for better or for worse. Rich is an epidemiologist and geographer, and I came across his work in my undergraduate days when I was interested in green space access. Earlier in his career, he focused on monitoring and measuring inequalities in health, and today his focus is on the potential for our environment to positively influence population health and health inequalities. He's particularly interested in understanding how places are part of the complex social and environmental systems which affect health and behaviour. And in this talk, Rich is going to describe a fusion of old ideas about why we have healthier and sicker places, and do these make healthier and sicker people, with some new technologies, with a range of different acronyms, which I'm sure he'll explain. And they might just enable place to sit at the heart of better and more equal population health. So thanks very much for joining us today, Rich. And we're all looking forward to hearing what you've got to say on the topic of is health the key to better and more equal population health? Over to you, Rich.
Thanks, Jenna. Right, let me see if I can share my screen here. Okay, so can everybody see the slides? I'm assuming
that's fine. Yeah.
Awesome. Okay. Thanks, everybody. Thanks for the invitation to come and talk today. I've really enjoyed putting these slides together because it's a moment where you kind of pause and think about what it is you're doing and where your research is going, but also have a chance to look back at some of the things you've done previously. So is place the key to better and more equal population health? Listen, if you need to leave now, the answer is yes. So I'm going to spend about 40 minutes explaining why that is. So the starting point for today is that place is a word we hear more and more and more. Everything seems to be place-based these days: interventions, policy, inequality, and planning. And as I was putting these slides together, I was thinking, I wonder if that's really true, or perhaps it's just my perspective. So as all good scholars do, I did an intense, detailed, rigorous study on this, and I stuck place-based into Google, expecting to find, you know, a few million hits, and actually there's kind of 4,338,000,000 hits if you type place-based into Google. I have, of course, reviewed them all, and I can safely say that place-based is flavour of the month at the minute. So what I want to do is to talk about some theory today. I'm going to start off talking about theory and then move on to some new ideas. And I'm going to present some results, but actually quite a lot of the stuff that I'm going to present in a seminar like this is really work in progress. Perhaps some what I call kind of higher level things where we're working on it. So hopefully it will be stuff that you haven't seen before. I quite like to do a bit of a whistle-stop tour in this kind of seminars. So I'm going to be presenting ideas and examples rather than kind of methodological details and depth. I hope that's okay. Okay, so we are largely epidemiologists in our world, population health people, and generally, when we use place, we use it as a spatial unit conventionally. We tend to use it as an aggregator for data. And when we do that, we see that health varies like massively from place to place. So I'm sure many of you are used to seeing maps like this. So here's life expectancy in the UK, men on the left and women on the right, data from ONS. And when we look at maps like this, you know, it doesn't really matter what the scale is. We see some darker colours, some lighter colours, sometimes right next to each other. We see that health varies according to where you are. We can be a bit more flash, so we can draw maps of change over time, and we can do them in funky ways. So this is a kind of cross between a bar chart and a map. So this is Scotland. These are deaths from assault in the late 70s. What I'm going to do is jump forward 20 years. So you'll see the shift. So you can see those chimneys rocketing out of kind of west central Scotland. Let's just do that again. So we can see that over time we have had some changes in the geography of assault. But actually, when you look at these maps, what you see is that most places in Scotland really didn't change very much over that time period. And that's going to be a bit of a theme running through some of the things I want to say today. So we can draw maps, right? And often that's as far as our place-based thinking goes in epidemiology. But I want to spend a few slides just thinking a bit more deeply. And I'm going to start with a quote from a bit of an academic hero of mine. This isn't David Harvey, by the way. This is a Gormley statue. So David Harvey was, still is, a geographer, an urban theorist, a Marxist, and he's written some of the things that have influenced me most profoundly in my kind of career. And I love this quote because he says, "But place has to be one of the most multi-layered and multi-purpose words in our language," which is a glorious way of saying, oh my God, it's really complex and it means different things to different people. And if you look in the geography literature, the urban geography literature, which is vast, people have spent an awful lot of time thinking about place and what it is, and not really in relation to health at all, but of it in itself. So this is a quote from a textbook that I particularly like, from Paul Knox and Stephen Pinch. Stephen Pinch taught me when I was an undergraduate. It's sort of been quite an influence on my thinking. And in this book chapter, they're actually using the word neighbourhood when they're talking about place. And they list the functions that neighbourhoods have. I'm not going to read them all out, but you can see them written in yellow there: economic, locational, structural, and social reproduction. And it's social reproduction that I want to spend a little bit more time thinking about today. So if you look at geography textbooks, urban theory textbooks, what you see is that actually there's an incredible variety of things which are connected to and part of place and this everyday experience that we all have of being in a particular place. And I guess the thing to stress then is this. So this is the very famous Dowgren and Whitehead socio-ecological model of health from the early 90s. It's an incredibly influential diagram. And what it basically says is, here are all the wider determinants of health. And these will be familiar to an audience like you guys. And my point here is that actually almost everything in this diagram has been written about by urban geographers as essentially being a core function of and feature of places. So the kind of education you have access to, your work environment, your unemployment rate, this is basically all about place. So in effect, this Dowgren and Whitehead model is really a model of geography. And that's one of the arguments I want to make. So it's no surprise that there is this strong connection between places and health, when basically almost all of the things that drive health are really features of place. Now, when we're talking about place, just to kind of iron this out fairly early on, obviously scale and definition matter. And I really like this quote from Paul and Stephen. In the final analysis, each neighbourhood is what its inhabitants think it is. That means that the definitions and classifications of neighbourhoods and communities must depend on the geographical scales of reference used by people. And that's a kind of crucial theme, and I want to start off with in theory, but then move on to thinking about in practice later on. So the places that we inhabit, how we define them, how we experience them, depends on us. Now, that's an easy thing for a theorist to say, but actually, if you're involved in empirical research, as we all are, that is quite a difficult thing to handle. So we're going to be thinking about that in a little while too. Okay, so I want to start off then by thinking about a particular aspect of place in health, really from a very upstream perspective, upstream in the sense of the wider drivers of population health and inequality. So obviously, some places change. You know, what's on the surface gets changed. We rebuild roads and houses. But actually, over long periods of time, many places or many aspects of place stay the same. So this is Venice. So of course, what happens in Venice is very different now to perhaps 100 or 200 years ago, but actually physically, it's more or less the same. Now, I want you to hold this idea of places staying the same in your head for a minute while I introduce this idea. So I think in geography, and in population health, we need to think about places as being like fields, but we're growing lives rather than crops. Now, the reason this is important is because if you think about a field, if you get the environment right, it nurtures healthy crops season after season. And it's the same for places. If you get the place right, we can potentially nurture healthy people generation after generation. But if you get it wrong, the adverse consequences are perpetuated. And I've got a good illustration here of to back up what I'm arguing. So in 1896, a guy called Charles Booth, who was a philanthropist living and working in London, he surveyed large areas of the city in London. He did it house by house. So they actually mapped the streets, they drew the houses on, and in true geographer style, they coloured them in. And they coloured them in according to the social class of the people living in these houses. So you've got a map of social class building by building for 1896. So a long time ago now, God, when I was looking at this, it's 20 years ago, working with Danny Dorling, amongst others, we got this map and basically we digitized it and we dropped relatively, for then, contemporary digital aerial boundaries onto the map and derived a poverty index based on Booth's map of London in 1896 for 1991 aerial boundaries. We did this using GIS, and you can see the map there. I don't know if you can see the mouse there. So this is the map here. This is a poverty index of London in 1896. And then what we did was the same thing for census data from 1991 to derive a poverty index there. And if you look at these two maps, you can see that they're really, really similar. So this is the geography of poverty in central London 100 years apart. So we then explored how well each of the indexes predicted mortality rates in London in 1991. And what we found was that the Booth index was just as good, if not better, than the 1991 census-based index at predicting mortality. Now, of course, the people underlying this map are completely different. It's 100 years apart. But my point here is that the spatial and social processes occurring in central London, which give different kinds of people different kinds of lives, were robust. So in a posh way, what I'm saying here is that economy, society, and geographical space, they write each other. They're all mutually involved in constructing things. And we call this the socio-spatial dialectic. Now, if you speak to an epidemiologist, and particularly a statistician, and you say, oh, you know, I think that basically place is a really strong influence on health, well, they'll shake their heads and say, no, if you run a regression model and you've got individual markers of wealth, they will be much more significant or a stronger predictor of health than any kind of marker of place in your model. But what I would say to them is, what geography tells us is that it's the places, the neighborhoods that are producing the society and economy. So those individual markers of wealth are a consequence of a geographical process. So to put it bluntly, we have richer and poorer people because we have richer and poorer places. So society and space are co-authors. They write each other. Now, just in case you're a bit skeptical, my final example on this particular part of the talk is this photo here. So this is a picture of Kigali in Rwanda, where I was lucky enough to go 3 or 4 years ago now. And there's various hills in Kigali, and here we are quite close to a bottom of one of the hills, and you can see these are the kids coming home from school, and you can see this is a house here on the left. So these are the circumstances in which these kids live. This is what the neighborhood is really like. So if you carry on up this set of stairs and you go over a few roads, you get to another neighborhood where the houses look like this, just within perhaps a couple of miles of each other. So what I'm arguing is that essentially the kids who grow up in this environment are going on to have a life, an economic life, and a social life, which will be reflecting this kind of environment here. And the kids that grow up in this neighborhood will be going on to have the kind of life that we can all infer from that picture there. That is what neighborhood and place does. It sets most of us off on a particular path. So I guess so far then I've been arguing that places can be very different, and often many aspects of them change very little over long periods of time. And I think the thing that we don't think about enough in population health and inequalities is that place itself is a key upstream contributor to population level health inequality. It's where our inequalities get reproduced. And that's why we struggle so much to tackle them, at least in the shorter term, because we've got this whole system of fields that continually reproduces this socioeconomic inequality. Okay, so now I want to move a little further downstream and talk a bit more about the immediate or perhaps the direct impacts of places on health and behaviour. And I guess this will be more kind of familiar territory to many of us. So quite obviously, some aspects of place, some aspects of the environment that we encounter where we're there, or the people that we interact with, they can hurt us. And some aspects of places, they can help us stay well and stay healthy and happy. And actually in our team, we're particularly interested in what it is about places that can help us stay well. But the point, fairly obviously, is that if we know that aspects of place can influence our health quite directly, in a more sort of downstream sense, then in theory, place and its attributes should be a lever that we can pull to improve health and narrow inequalities. And that's what we want in our team and in our field. We want to be able to design, build, and manage places to be salutogenic and equigenic. So what I mean by salutogenic is something which can protect and improve health and well-being. And what I mean by equigenic is a place which can act to constrain or maybe even reduce inequalities in health. That's what we're looking for in our science. The good news is it's not just us that wants this. So the stakeholders that we work with in our research team are powerful. They control, they influence many aspects of the built and physical environment at different scales. So whether that's a local authority planning agency, or whether it's a land manager like the Forestry Commission as was, a third sector agency, other sorts of charities, a whole range of people have actually got incredible influence on what it is that we encounter when we step outside our front door and we interact with people and we interact with places. So the power is there. What they're looking for is evidence to help them make those decisions. And that's what we do. So I mentioned in the little abstract for the talk, so the MRC funds us here in the Social Public Health Sciences unit to think about place and health. And this is why we do it, because there's a potential here for positive influence. So our long-term aim in the program that I run is to understand how urban environments do or could be modified to protect and improve health and reduce inequalities. That's what we do. And what I'm going to do in the rest of the talk is to structure some of the examples of the research that we do around the three work streams that we have. And the examples that I've picked are ones in which we're using new technologies and new methods to try to gain some novel insights. In one or two cases, they're not new at all, but they are new to us. And I'll try to highlight those. So in the team then, we have three work streams, and we focus on trying to explore and show how places change, how people use places and how that might influence their health. And then with that knowledge, how could places be changed to try to improve health and reduce inequalities? So let's think first of all about how places change and what we can understand about that. Okay, so it's a fairly kind of conventional epidemiological idea that if you could observe change in something and then observe the effects, you get an insight as to whether whatever it is that you've changed actually causes or has a causal relationship with health. And it's just the same for places. So if we can observe change in the characteristics of places, here's a wee neighborhood, maybe we put in some kind of public transport and we follow that place over time, maybe we can see the consequences of that for health and related behavior. Maybe more people start active traveling, for example. Now, over the course of my career, I've been involved in a few studies which come close to a controlled, not a trial so much, but as a natural experiment. They're actually very rare in place-based research. It's a very difficult thing to do to operationalize change in some aspect of an environment in some places and not in others, and observe what happens over time. But I was very fortunate to be part of a project led by Catherine Ward-Thompson at the University of Edinburgh, in which we evaluated the impact of something called WIAT. Now, WIAT stands for Woodlands in and Around Town, and it was a then Forestry Commission-led project where basically they go and they find bits of urban woodland close to deprived communities, and they improve the woodland. They put in footpaths and signage, they make them safe, they open them up, maybe put some facilities in, and they also have a program of social promotion to try to get more people to visit the woodlands. And what I've got on this graph are the results. So this was a really difficult, long-term and expensive study, multiple waves over several years. So on the graph, I've got the results for wave 1, which is baseline, and then wave 3, which was our final follow-up. I think it was about 3-4 years after intervention. The green bars are the intervention neighbourhoods. We had 3 of those, and the black bars are the control neighbourhoods, and we had 3 matched, similar as we could get them, ones of those. Now, what happened essentially was, over time, we saw very small positive changes. So if you look at this part of the graph here, so between baseline and follow-up, essentially the number of people who were visiting the woods once a week went up a bit, and in the control areas it went down, and the number of people not visiting the woods at all in the intervention areas went down a bit, and in the control areas actually it went up a bit more. So on the face of it, that's quite a positive thing. But do you know what? It was just bloody hard work getting these results. And actually, the scale of the change was really small. You know, not much changed. And one of the things that we discovered through doing this work was it was incredibly difficult to hold the control neighbourhoods unchanged and to allow for context in the intervention areas. They were all slightly different, inevitably. And crucially, even though this was a multi-zillion pound grant, and we worked really hard to sustain the cohort over a period of time, it wasn't long enough to see the changes in behaviour and then ultimately mental health that we wanted to see. So when we think about what we might do now, we need to reflect on this kind of study, and I think it's pretty flawed. And what we need to do is to try to understand the impact of built environment change in lots of places, to try and do it in as many places as we can and over much longer periods of time. And this will allow for the fact that places differ slightly in their context. So that's what we're doing right now. So we've got an ESRC funded project in collaboration with other colleagues in Creche and Open Space at Edinburgh. And what we're going to do is not just do a few of the Wyatt neighbourhoods, we're going to do all of them. So we've got a big GIS project to capture the changes that have occurred to these woodlands. And we're going to use linked data, Scottish longitudinal study, some prescribing data and child health data, which are routinely recorded to track the impacts of the entire Wyatt Forest Intervention Programme. So you're probably waiting for a results slide next. We're doing this right now, we've just begun. But I think it's something which is enabled by both the GIS tech and the linked data tech, which are available to us now, and hopefully we'll get some progress. Now, on a slightly kind of wider scale, again, it's not just change in green space and woodlands that we're interested in. We want to track aspects of change in terms of things like housing and public transport infrastructure and roads and footpaths. And I'm delighted to say we've just begun working with Cambridge and Imperial on an MRC-funded project to extend a built environment change atlas that we had begun to pilot for Scotland. We're going to try and do this for the whole of Britain using Ordnance Survey data to capture the change in built environment over time. And the point of doing this is to make those data available to you and to the public once we've created them, so you can understand what kind of place you live in and how that's changed over time, and perhaps use that for your own intervention studies. So again, a step forward in technology and computing power and data will enable us to take a different perspective on place. But continuing the focus on change in environments over time, I want to spend a few minutes just talking about work in Creche in Edinburgh and with Glasgow Caledonian University on change in alcohol and tobacco outlet environments. So we understand that the availability of alcohol and tobacco retail is associated with harms, with consumption and harms of those products. We understand that in general terms, we see more alcohol and tobacco outlets in poorer areas, certainly in Scotland. And we also understand that poorer populations seem to be more sensitive, basically have experienced greater harm for a greater amount of retail environment that they are exposed to. But actually, most of the research on this is cross-sectional. And what we've been trying to do in this recent project is to make that work more longitudinal. And that's opened the door to us exploring some of the finer points of the geography of alcohol and tobacco retail in more detail. So I'm going to show you some maps looking at, actually we're going to focus on tobacco retail today. When we map retail environments for alcohol and tobacco, we use something called kernel density estimation. So this is just basically a posh way of combining together the information about the number of outlets, the number of places you can buy these products, and the distance to them. And when you put those things together, you create a surface which represents availability of the products. Higher KDE, basically more available products. So we've begun the project by creating measures of availability for 3 different time points, 2012, 2016 and 2020. This is a Scottish-based project. This is a map of change in tobacco outlet density between 2012 and 2020, and I'm only going to show the tobacco stuff just today. The redder areas are those which have experienced greater increases in tobacco retail outlet density. So what we find when you look at the whole of Scotland is that basically the most interesting things in terms of changing KDE values are in urban Scotland. And we're going to have a quick look at Glasgow. So this is a map of Glasgow, just to orientate you. I hope you can see my mouse wiggling. So this is the city centre here. That's the West End where the university is, and that's the River Clyde kind of running in the middle. Redder areas are those with greater KDE, greater availability, and these are the data for 2012. So when we look within the city, we see quite a complex geography of availability, and we see things being very different for different communities in different parts of the city. So we're going to jump to 2020 now, and I want you to keep your eyes on this bit of the city here. Okay, so this is the geography for 2020. I'll just do that again in case you were blinking. 2012, 2020. So what we see is a shift, and in the sense that tobacco retail seems to have reached out like a big kind of evil hand, if you like, grabbing into the East End of Glasgow. Now, what do we think about when we think about the East End of Glasgow? We think about deprivation and poverty. So the map here on the left is a map of income-related deprivation, so that the more kind of wildly pinky purple areas are more deprived. That's the East End there. But it's interesting, if you were to draw, as I have done here, a scatter plot of the relationship between the change in tobacco retail on this axis and increasing deprivation on this axis, you can see that actually in Glasgow, globally, it's a weak relationship. Now, I should just stress that the stage we've reached in this analysis is that we're still modelling deprivation at 2020. So it's a change in alcohol tobacco retail outlet against deprivation in 2020. So that's just one caveat. But the point still holds. It's a weak global relationship. But if we think about where in Glasgow the exciting changes are happening, well, it's this part of the city here. So if we just draw a regression line for the areas shaded in yellow here, well, there actually we see quite a steep relationship with deprivation, as the cross-sectional literature might suggest. But if we jump over here now, this is Paisley, another poster area for deprivation and poverty in Scotland. Well, in Paisley, a poor area, well, we don't see any relationship at all there. So what this tells us is that we need to be thinking in a more nuanced way about the relationships between variables, between risk factors and outcomes when we think about geographical space. And we've been exploring a technique that's been around for a wee while, but isn't actually used very much, called geographically weighted regression. And this asks formally whether and how associations between variables vary across space. So rather than doing one single regression for everywhere, in effect, we end up doing lots of regressions for different parts of the city. And what you produce from that is a map like this one. So this is a surface in which now we're drawing the regression coefficient for the relationship between deprivation and tobacco retail outlet change. And you can see that we've got really sharp spatial variation. So the red areas are those in which we see a relationship where we have more deprivation experienced an increase in tobacco retailing. And the blue areas, sometimes right next to those red areas, we saw a fall. So this really calls attention to the fine nuance of place. And of course, it makes us think about, well, it's clearly not just deprivation that's driving these changes. You know, how does this fit into the planning system? How does it fit to the wider urban system and the urban landscape? Okay, so I want now to move to how people use places. And we're thinking here about where do they go, what do they do, and how does that affect their health? Now, an awful lot of epidemiology and public health still assumes that your neighbourhood of residence is a good proxy for the environment which might affect your health. So we know where people live, we maybe have some understanding of the facilities or the retail environment or the air quality or something around the house, and we assume that that's exposure. But obviously, other places in towns and cities are available, and most people are moving around and experiencing influence on their lives and their health from other parts of the city. So how can we capture this? Well, we can do perhaps finer scale geography if you want to have a static boundary around where you live or your school or wherever it is. But really what you want is to track where people go. And the way to do that is to use GPS devices. So these are devices which I'm sure you all know record your location constantly using connections to satellite. Now, in the previous kind of 5 years in the program here, we collected GPS and accelerometer data on about 800 10 and 11-year-olds across Scotland. It's a study called Spaces. And what we're doing right now is going back to those kids, trying to get back to the same kids a few years on. And we're worried that this is what they look like now. But actually, the study's going quite well. And even though they are kind of 16, 17 years old now, they're working with us really well. So these data will become available, we hope. But in the meantime, we've been using Spaces 1, the 10 and 11-year-old data, to ask, where does their mobility around their city and their town take them? And what is it that they encounter? And this is work led by Fiona Carroll, one of our colleagues in the team. And what she's been looking at is how inequalities in exposure to tobacco retail vary according to how you measure them. So this is a graph of inequalities in exposure to tobacco retail if you measure it based on the fixed area around where the kids live, so their neighbourhood, basically not taking account of where they go day in, day out. And if you measure it that way, we see about a 3-fold difference in exposure to tobacco retail between the most deprived and the least deprived kids. But if you use a GPS device to work out exactly where the kids went in their daily routine across the week and at the weekends, so we know where the GPS device is, it's on the kid, and we know when they encounter a shop, there we see a 7-fold inequality in exposure to tobacco retail. So the poorest kids are 7 times more likely than the richer kids. And we already know that poorer folk are more influenced by the retail environment that surrounds them. So that's a really interesting insight to how GPS can help us understand what's really going on in these kids' lives and what might be driving their health and behaviour. So we can do it to exposure to tobacco retail. We can also, using some interesting new tech, and this is work led by John Olson, we can look at adverts. So Google Street View, those crazy cars that you see driving down the road taking photos of everything, offers us a chance to see what's being advertised. So we used Google Street View to see what was being advertised at the bus stops that the kids in the Spaces study went past. And we were interested to see whether the advertisers were sticking adverts for unhealthy products closer to where the poorer kids might be. And what we found here was, perhaps not surprisingly, that poorer kids were in general more likely than richer kids to encounter bus stops at all. But then when we looked to see what was advertised on those bus stops, we did see some really interesting differences with, for example, significantly higher advertising for ice cream, for alcohol, and less likely to be advertising perhaps healthier products like mineral water. So using these technologies, we're able to get a better understanding of what people are exposed to and how that might influence their behaviour. Now, I guess here in the team, we're perhaps best known for some of our work on green space, urban nature, and the range of the ways in which having green spaces in the city is positive for health and behaviour is just quite extraordinary. We have influences at a population level, so green spaces can reduce air pollution, they can help in urban cooling if you happen to live outside Scotland and that's a problem, can help with water management and flooding. And then there's a whole variety of pathways through which individual contact with nature is good for you, and the most important of which is a direct impact in terms of stress reduction and psychological restoration. But actually, I don't really want to talk about the health impacts of green space today, because I feel the research agenda in green spaces is shifting a bit to be thinking less about the health benefits, which are pretty much proven now, towards thinking about, well, who is it that gains those benefits and how can we think about that? So this is a graph of visits to green space reported by survey data, and it's for 4 different cities in Scotland. And what we've got is the visits broken down by socioeconomic position. So AB are higher occupational grades, down to DE, the lower occupational grades. So this is observed survey data. And what we see in all the cities is a sharp inequality, such that higher socioeconomic position people are much more likely to visit green space than lower socioeconomic position people. And that's the case in all the cities. But what's interesting to us here is that in Edinburgh, we see that inequality, it's actually, in relative terms, lower than in other cities. There's an 11-fold gap in Aberdeen. It's only just over 2 in Edinburgh. And overall, for all the respondents, even the poorer ones in Edinburgh, we see higher rates of visitation. So we've got this kind of inequality within cities, but also between cities. And we're kind of interested in what might be driving that. So starting to understand some of the behavioural drivers of visiting green space. Why is it that some people do and some people don't? And how is that related to geography? So from the Glasgow Centre for Population Health, Russell Jones and Pete Seaman have written some really interesting stuff where they interviewed people about their decisions about whether to visit particular parks and green spaces. And what they found in this qualitative study was that people said they were really strongly influenced by who else is or might be in these parks. So the perceived differences with other users, particularly in terms of socioeconomic position or status, affected the willingness of the respondents to visit a green space. Now, what's interesting here is there are no other data about this. There's no quantitative data set that we can draw on to really unpack this. Essentially, there's some interviews and a bit of a theory from these people. So what we were interested in was whether we could do something with that empirically to test out whether this social comparison was a driver which would explain those between and within city differences in visiting. And to do that, we used an agent-based model, or an ABM. So an ABM is a computer simulation of individuals, how they interact with each other and their environments. And the crucial thing about an ABM is that the code allows the interactions that take place in the simulation to change the behavior of the individuals you're simulating and the environment that they're operating in. So it's a dynamic systems model which can change and react. So what we did was to create an ABM in which we had the 4 cities, and we had people living in the right neighbourhoods, at the right level of poverty, and they had proximity to real green spaces. So we built this entire model. This is work led by Stefano Picassier in the team. He built this model, and we gave the individual agents some very simple behavioural rules in which they would maybe go to a park, have a look to see who was there, and respond according to whether it was people who were similar to them or different to them. And some of the agents wanted that and some of them didn't. So the system was driven by the interaction of agents of different socioeconomic situation. And as the model evolved, what we were interested to see was whether the patterns that we had observed in reality in the survey data would emerge when the decisions the agents were making were simply based on reacting to what kinds of people they saw in the park and whether that was something that they enjoyed or they didn't. And what's really interesting is what we discovered was that it was a combination of the urban geography of Edinburgh, which has a particular configuration of neighbourhoods and a particular configuration of parks, and this social comparison decision-making was indeed enough to make those inequalities within and between the cities emerge. So what we can say is that that theory alone, when we made the theory real in the simulation, if you like, we made it empirically real, was enough to explain those inequalities in visiting behaviour. I'm going to come back to ABMs in a little while. Okay, so moving towards the last phase of the talk, I guess the key question for all of us is how can we use this information to change places, to make them more salutogenic and equigenic? And my first example of the research we've been doing on this is to come back to thinking about tobacco. And again, this is work that's been led by Fiona. So it's great that we've got an understanding of where tobacco retail is and possibly how it's changing. But what policymakers want to know is, what can we do? You know, can the tobacco retail landscape be a lever to try to reduce inequalities in exposure and try to drive down exposure overall? Now, the brilliant thing about holding information on a retail landscape in a computer, in a geographic information system, is that you can manipulate it. You can change the geography of retail in ways which are plausibly related to the kinds of things that policymakers might want to do, to show the policymakers what the impacts would be. So FEE simulated a range of policies restricting who can sell tobacco, where tobacco can be sold. What we're interested in is what policies would provide the greatest percentage reduction in neighbourhood density of outlets overall, but also have an impact on the inequality in the density of neighbourhood retail outlets. Because what we discovered is that not all policy choices are equal. Okay, so here are the results from the study. And what this graph is showing is the percentage reduction in the mean neighbourhood density of tobacco retail according to a whole range of different policy scenarios. So for example, we said, well, what if you could only buy cigarettes and tobacco products in a supermarket or an off-licence or a pharmacy? Or what if you stopped selling them anywhere near a child's space? So that would be a school or a play park. Well, what if we had a cap on the density that was allowed at like a minimum spacing? That happens in Madrid, for example, where you can't have tobacco shops too close together. What if we stopped sales anywhere near schools? A whole variety of different policies. And we were able to show that they had really quite different impacts on that mean neighbourhood density, such that supermarkets, restricting sales to supermarkets only, would have the strongest influence in reducing mean density. Something you can only show in a simulation. But what was really interesting was we were also able to unpack the impact of these different policies on the inequality in density between the most and the least deprived neighbourhoods. So this one here is the baseline scenario. And then what FEE did was to map out the impact in terms of inequality of various policies. So these ones moving here, for example, restricting to on sales only, and these ones here, for example, the restriction to supermarket only, these ones increased the inequality between the richer and poorer neighbourhoods. So you might be driving down density overall, but you're actually widening the gap between richer and poorer places. And these ones had the action of reducing inequality. So a really interesting approach to trying to understand the influence of a shift in retail landscape on different aspects of exposure, the amount of exposure overall, but also the inequality. Okay, my last example, you'll be pleased to know, is another agent-based model. So I think this is possibly our most sophisticated agent-based model so far. So this is work led by Yoni, who's sadly had to go back to Israel now, but it's a great study. And what we did was to take the information that we had on the way in which children behave from our spaces data set, our GPS data set. So that tells us where the kids go and how much physical activity they're getting when they go there. And we joined that together with other information from the literature to create a simulation of a child's day. Now, I'm really hoping that this is going to run. Okay, so what you're going to see in a minute is a little animation. So the little blue dots are kids, and they wake up in the morning and in their house, and in the model they go to school, and they spend the day at school doing their school day, and then after school they come out of school and they make decisions around what they want to do. Do they want to go and kick their football around with their mates? Do they want to go to some kind of after school activity? Are they going straight home with their parents? If so, are the parents choosing that they're going to walk or are they going to drive? So he recreates the entire school day of these kids based on the data that we had and data we were able to draw on from other surveys. And he puts it into the model. And through the day, the kids are accruing physical activity. They're wearing kind of imaginary accelerometers, if you like. And so he builds the model and he tweaks it until he gets to the point where the model itself recreates the levels of activity that we know from data the kids were actually getting in real life. So we're reasonably sure that the model is a replication of what these kids are actually doing. And once you've done that, well, then you can start to play with stuff. You can impose policies on the kids. You can change the environment. You can change the way in which they run their day. And that's exactly what he did. So he compared a number of different interventions based on trying to encourage the kids to spend more time in their neighborhood after school, to go and kick a ball around, for example, to impose greater amounts of physical activity in the school day. So this bar here, which I hope you can see, the tallest kind of purpley grey one at 81 there. So that was, what if we gave kids, every kid, an hour of physical activity in the school day? What if we banned cars and made them walk everywhere? What if we just made them walk to school? So you said you can't have the car on the school run. What would be the impact on the overall amounts of physical activity that the kids accrued? But also, crucially, on that, the differences between the kids who were not getting any exercise beforehand and those who were getting a lot. How would it help to redress the distribution, the inequalities in the distribution of exercise? And one of the interesting things, or the most interesting things I found about this study was, not surprisingly, I suppose, if you impose an extra hour of physical activity on the kids in the school day, so basically they're all in school, they've all got to do it, that's the way that you get them the biggest increase in physical activity in the day. But some of the other policies had some really kind of interesting, unexpected consequences. So, for example, if you say to the kids, right, everyone's got to walk to school, what does that do to the distribution of exercise in the population? Well, it turns out that actually that favors the richer kids, because the poorer kids are already all walking to school because they don't have access to cars. Anyway, in the paper, if you get into it, you'll be able to see Yoni end up suggested some particular combinations of intervention which might have the greatest impact. So to finish up then, your messages to take home in your party bag. Places matter for health, and yes, they reflect inequality, but crucially, deeply upstream, places recreate the kind of social and economic structures we have in our society which drive population health inequalities. And if we don't tackle that, we don't have a hope of fixing population level health inequalities. So in our program, using these technologies and these new data sets and techniques, we're focused on understanding how place and experience of places might change over time. And crucially, how through understanding how people interact with their places, we're able to think what those places could be like, what policies and changes can we introduce to try to both increase population health, but drive down inequalities. I'm sorry, I think I'm just a few minutes over, but I will now shut up. Thank you.
Thanks very much, Rich.